Hello, everyone, and welcome to our module on delirium. Let's start by talking about the difference between dementia and delirium. So both of these are cognitive disorders, meaning they're disorders where there's disruption of cognition, which is the way we acquire and process and use information. So dementia is a cognitive disorder that has a chronic progressive cognitive decline. And I talk about this in detail in another video. There are a number of causes of dementia, but most of them are associated with a chronic slow decline, usually over years. And usually the cause of dementia is irreversible, although there are a few exceptions. In contrast, delirium, which we're going to talk about in this video, is an acute condition that can come on over hours or days. It has a waxing and waning course that goes up and down. It's not stable like dementia. And usually delirium, in most cases, is entirely reversible. Okay, so what are the clinical features of delirium? As I said in the last slide, it's an acute onset condition, so it's the kind of thing that can evolve over hours or days, in contrast to most forms of dementia, which evolve over months or years. Delirium involves disturbances of attention and awareness, so patients may be unaware or confused about their surroundings. They may have trouble paying attention and focusing on you when you're talking to them. There can be emotional disturbances. Patients can have a flat affect, or sometimes they can be agitated. And then there are many cognitive impairments that we'll talk about. Patients sometimes have delusions or even hallucinations. And if you haven't heard this term yet, you should be familiar with the term altered mental status. It's a non-specific term, which means a person has had a change from their baseline cognitive functioning level. And the most common cause among patients in the hospital for altered mental status is delirium. You will see this very frequently in hospitalized patients for reasons that we're going to talk about shortly. All right, so let's drill down in a little bit more detail on the clinical features of delirium. So it's classically taught that delirium has a waxing and waning course. So what does this mean? This means that in patients with delirium, they have fluctuations in their level of consciousness throughout the day. They can be lucid and responsive one moment and talking to you as if they don't have delirium at all. And then 30 minutes or a few hours later, they can appear drowsy or confused or inattentive. This is that waxing and waning course. It's classic for delirium. Sometimes if multiple people talk to the patient at different points of time, one of them will say the patient was clear-headed, the other will say they were very confused. That's classic for delirium. And this is a big contrast with dementia. Patients who have dementia do not display this type of variability, so they aren't lucid and clear one moment and then confused the next. Delirium is also associated with fluctuating levels of arousal. So what does this mean? This means that patients who are delirious can be hypoactive sometimes, where they're lethargic and drowsy and yawning and wanting to nap. And then they can be hyperactive other times where they're agitated and restless. This is classic for delirium. Patients with delirium also have a decreased attention span, so they can have trouble focusing on a conversation or following a conversation. They have trouble completing tasks. They get very easily distracted, and it can be very difficult to engage with these patients. If you try to talk to them and get them to engage with you or do an activity with you, it can be very hard for them to do this because of their poor attention span. And then delirious patients also classically display disorganized thinking. So this means speech that's illogical or it's tangential or it's incoherent. If you ever try to talk to a patient who is delirious and you're trying to get their medical history, it can be very difficult because they jump from one topic to another. A lot of the things they say are confusing or simply don't make sense at all. Some patients with delirium will develop hallucinations, and these are usually visual hallucinations. So they will see people or animals or items in the room that aren't actually there. I once had a delirious patient tell me that the police had come to visit him in his room, but that was just a visual hallucination. And this is in contrast to schizophrenia. As an aside, patients with schizophrenia usually have auditory hallucinations. They hear things that aren't actually there. Contrast, the hallucinations in a delirious patient are usually visual. And then delirium is famous for disturbing the sleep-wake cycle in patients. Often patients with delirium have reversed sleep patterns. So at nighttime, when they should be getting tired, they become agitated. This is sometimes called sundowning. It's when a patient with delirium becomes agitated at nighttime. And then during the day, when they should be more awake, they can be drowsy and lethargic. It's super important to understand that delirium is never a primary disorder. It's always secondary to another cause. And so when you see a delirious patient, you always have to ask yourself, what's going on with that patient that is triggering this delirium? Some of the common triggers for delirium are listed here. A big one is infection and fever. You will see many hospitalized patients who have an infection, have a high fever, and they develop delirium. You can also see it from metabolic derangements, things like hypoglycemia or hyponatremia. Pain can cause this in post-surgical patients. There are also drugs and toxins that can cause delirium. We'll talk about these in a second. And patients withdrawing from substances like opioids or alcohol can also develop delirium. Another classic trigger is simply being in an unfamiliar surrounding in a patient who has baseline cognitive dysfunction. So, for example, a patient who has dementia and is put in the hospital and suddenly doesn't recognize the room around them. And in addition, that patient has infection and fever. That is a classic setup to develop delirium. So, hospitalized patients, elderly patients who have baseline dementia and things like pneumonia or sepsis commonly develop delirium for this reason. It's long been known that there are many drugs that can cause confusion, especially among the elderly. But in the 1990s, a clinician named Beers developed a so-called Beers criteria or Beers list, which is published regularly by the American Geriatric Society. And it's a list of so-called PIMS, which are potentially inappropriate medications. These are drugs that should be avoided in adults over the age of 65. And that's because these can cause things like confusion and delirium. Beers criteria or the Beers list is published to try and remind providers of drugs that they should avoid to reduce adverse drug events in the elderly. So what kind of drugs are on this list that can trigger confusion and delirium in the elderly? Well, a big group of drugs are the anticholinergic drugs. These are drugs like atropine, also drugs that have anticholinergic side effects like amitriptyline, which is a tricyclic antidepressant, or paroxetine, which is an SSRI. Anything with anticholinergic effects can block cholinergic receptors in the central nervous system, and that can trigger delirium and confusion. There are also many non-cholinergic drugs on the list. One of the biggest groups are the benzodiazepines. Use of these drugs in the elderly is discouraged because it can cause delirium and confusion. Same is true of barbiturates in the elderly. Same is true of antihistamines among the elderly. And if you have a minute, it's worth Googling the Beers list or the Beers criteria just to scan the whole list. You don't want to memorize it, but you should get a sense of the type of drugs that have confusion as an adverse effect. Any of these drugs, when they're used in the elderly, can trigger a delirium episode. Let's talk briefly about the EEG in patients who have delirium. So an EEG is an electroencephalogram. It's a diagnostic test that you obtain by placing leads in the patient's head, like what's shown here, and you record the voltage of electrical activity in the brain. And there are different leads for different parts of the brain, like the frontal lobe and all these lobes I've listed here. Many disease processes have characteristic patterns, but the key thing to know about the EEG in terms of cognitive disorders is that it's usually normal in dementia, but it's almost always abnormal in delirium. The finding that you see on EEG in delirium is diffuse slowing of the electrical activity in the brain. And this is in contrast to dementia, especially Alzheimer's disease, where the EEG is usually normal. Okay, now let's talk about some stuff that's super high yield for board exams and real life, and that's the treatment of delirium. So the mainstay of treating delirium is to treat the underlying cause once you've identified it. So if a patient is delirious because they have infection or because they're withdrawing from alcohol, you want to treat those problems to resolve the delirium. If the patient is hypoxemic, you want to administer oxygen. If they have pain, you want to treat that. If they're volume depleted, you want to hydrate the patient. So this will come up on your board exams. They'll describe a delirious patient and they'll ask you for a treatment, and the answer will be administer oxygen. And many people will not pick that answer because they'll think, why would oxygen help with a cognitive disorder? But if the cause of the delirium is hypoxemia, then the oxygen can eliminate the delirium. Also, a super important thing to do is to review the med list. You want to avoid all those medications on the Beers list. You want to see if any of these drugs could be triggering the delirium in your patient. And then you should be aware that restraints can sometimes be administered to patients with delirium, but this is an absolute last resort. This is a picture of a patient being restrained and tied to the bed in this image on the slide here. We try to never do this, and in a board question, this is almost always going to be the wrong answer. You only want to use restraints when you're unable to redirect patient behaviors, and this is usually after attempting antipsychotic medications we'll talk about in a minute. Basically, you have to have exhausted every single other option before you administer restraints, and like I said, it's usually the wrong answer in a board question, not always, but usually. Another super important thing to know about delirium is that it's very common in hospitalized elderly patients, and one of the reasons for this is because the hospital environment often worsens confusion. Hospitals are noisy, they sometimes have poor lighting or no windows, patients frequently have to change rooms, and so all of these things can trigger delirium, just being in the hospital environment itself. And so we try to make a calm, quiet environment as much as possible, especially for elderly patients in the hospital, and one of the reasons we do this because we want to minimize the likelihood that they will develop delirium. So there are a couple of things that are done in the hospital to try and create a calm, quiet environment and minimize the risk of delirium. And these things are shown in this slide here. Many of these things have clinical trial evidence that they reduce the risk of delirium and confusion. So a big group of hospital interventions are so-called orientation protocols. These are things like putting a clock on the wall and a calendar on the wall, and having windows that are open to the outside so the patient can tell whether it's night or day. One of the big reasons patients can develop delirium is because they don't know where they are in the hospital, and so clocks and calendars and windows help to keep them oriented, and this reduces the risk of delirium. Cognitive stimulation has also been shown to help reduce the risk of delirium. So this is things like visits from family and friends so that the patient doesn't feel isolated and alone. This has been shown to reduce the risk of delirium as long as you avoid overstimulation and you allow the patient to have enough time to rest and sleep. And so that gets me to my third bullet point, which is you have to allow for adequate sleep. If patients are kept up all night by noise and by blood draws and by blood pressure checks, they will be tired and they are more likely to develop delirium. And then lastly, early mobilization has also been shown to reduce the risk of delirium. Once again, when patients are bedbound all day long, that can become frustrating, they can get agitated, and that can make delirium more likely. And then the last thing I'll talk about in terms of treatment of delirium is antipsychotic medications. We do sometimes use drugs to treat delirium. However, you should be aware that there are lots of studies showing these drugs have negative effects. They sedate patients, they prolong their hospitalization, they prolong their recovery. So drugs to treat delirium are only used as a last resort. Usually the patient has to display severe agitation, and usually there has to be a risk of self-harm. So for example, patients who are ripping out IV lines or combative with staff, that's the type of patient where you might use an antipsychotic drug. In general, there has to be no alternative available. So you have to have already tried to quiet the patient down and calm them down. And if those things aren't working and there's a risk of harm, that's when you go to antipsychotic drugs. The drug that's usually used is haloperidol. It's a typical antipsychotic. It's a dopamine receptor antagonist. I talk about it in detail in videos in the psychiatry section. Sometimes other antipsychotic drugs are used, like these three that I've listed here. But the most important thing to remember is that these drugs are a last resort and usually only when there's a risk of harm to the patient or staff. And that concludes our module on delirium.